Welcome to INEDCAST, the podcast where innovation meets education in hepatology and liver transplantation. I'm your host, Dr. Sanjay Satpathy, and I'm excited to bring you another thought-provoking episode. So today we are privileged to feature Dr. Amit Mathur, a globally recognized leader in transplant, hepatobiliary, and pancreas surgery, and a professor of surgery at Mayo Clinic in Arizona. As the surgical director of the liver transplant program, Dr. Mathur has extensive expertise in liver, kidney, and pancreas transplantation, along with complex liver and biliary surgeries. His research focuses on improving access to transplantation, addressing health disparities, and enhancing outcomes in end organ failure, while his work in transplant policy and finance has shaped the field in countless ways. So this episode features the engaging Q&A session that followed Dr. Mathur's compelling lecture, Liver Transplant for Cholangiocarcinoma. Ready for prime time? You will hear his expert insights and thoughtful responses to questions about the emerging role of liver transplantation in managing cholangiocarcinoma and the challenges and opportunities it presents. So stay tuned for this dynamic and informative discussion. And don't miss this chance to get knowledge from one of the foremost experts in the field. Let's get started. Thank you, Dr. Mathur. That was a fantastic talk. I think our audience will agree with that. So much of information and also so much of new knowledge that I think that comes from your own experience. So with that, I would open it for discussion. All right, Dr. Samant from Osner. Dr. Samant, please.
Hi, Amit. Great talk. We do have a protocol for transplant for cholangio extrahepatic, and we have good numbers. The question from you is we do have started developing working on intrahepatic cholangio to think whether they can be a transplant candidate. Uh, do you guys ask for merit exception in those groups if they are really good and you wait for 6 months?
Great question. And so I was worried about how much time I would have in this lecture that I didn't want to necessarily get into meld exceptions with the slides, but I'm glad you asked the question because it's something we talk about every day in our program. So now what the OPTN board has approved as recommended by the OPTN US Liver and Intestine Committee is a exception for the small intrahepatic cholangiocarcinoma. So those patients with tumors less than 3 centimeters, those patients are eligible for a MELD exception that's analogous to what we see with HCC in Milan criteria. So a median MELD at transplant of -3 based on the locality. So we do apply, we don't apply for the exception now, but we will have the ability to once that gets approved, and based on the data that's out there in the literature now, that has already been approved. So I think that will be common practice in the US for sure. And so we will certainly be doing that.
Thank you, Dr. Munges Pragala from Methodist Houston.
Dr. Mathur, that was a great talk. We always look forward to Mayo Clinic data to kind of provide us guidelines as to how to approach cholangiocarcinoma. They're always the leaders in this particular field. My question is more about, we focus on 1 year, 3 and 5 year survival. Obviously, that's the metric. But I think I'm more concerned about the cancer-free survival. I think that data is not as robust as survival, especially because these patients, intrahepatic patients that we pick and choose, generally the MELDs are good, they'll have lesser portal hypertension. So obviously, unless surgical or the normal complications that occur after transplant drives their survival, I'm more concerned about should we really make it prime time unless we improve the cancer-free survival? I mean, holding it to the same yardsticks of Milan criteria or San Francisco criteria, etc., which drives
I think it's an excellent discussion and question. And I think what I would like to see it, and I come from a context of primarily deceased donor transplant and at my center, and I think we have to ensure as stewards of deceased donor livers that we have equipoise across disease types with the long-term survival outcomes. And so, as transplant oncology is evolving, we want it to mirror what we do with HCC. We want it to mirror now. I mean, people are talking about liver transplant for colorectal mets with good survival, although not great recurrence-free survival. And so what we do with every cancer, neuroendocrine tumors for that matter, what we do with every cancer type, I think we have to be able to show that the outcomes are similar at the 5-year time point with survival. Now with recurrence, I think it really depends, I think, on the tumor type. I think with intrahepatic cholangio, there is a far greater ability for us to select therapies that will help us, and data is still emerging on all of that. But if we're able to better select the patients up front with, let's say FGFR fusion therapies where they have a targeted treatment strategy, those patients in resection do better, less recurrence-free survival. We'll be able to select patients better. But based on the protocol that has been described at Houston Methodist and MD Anderson, even their recurrence-free survival in the transplanted patients mirrors what we see in colorectal mets. So I would say that, yes, I agree with you. Recurrence has to be an important part of how we determine what's going to be best for a patient. But I think we have to be fair to all tumor types, all disease indications, right? I think we need to make sure that patients are getting the same. And I think for our context, as we think about this, we probably will be initially more conservative with selecting those patients that have tumor types that have actionable mutations, because we think we would get better outcomes with that. But only time will tell.
Thank you. I have a question, Dr. Mathur. Like many times we see patients with mixed tumor, HCC with cholangiocarcinoma, and sometimes by imaging, it is difficult to differentiate that. But the outcomes of those patients isn't it as good as HCC as compared to those of a pure HCC?
So we often, have that same diagnostic dilemma. We have an abnormal appearing lesion that's not necessarily LIRADS 5 type lesion. We do try to biopsy those to identify the path up front, but we often see it on explant that the mixed tumors are there. What we have found in our data, and then what was clear from what was described from Barcelona, is that mixed tumors that are small size do have equivalent outcomes to what we see with Milan criteria HCC. And so I think that's where we got the idea that we can, even if it's a non-mixed tumor, if it's just a small intrahepatic cholangiocarcinoma, the outcome should be similar. But for HCC, we are very big on using local regional therapy. And so I think that still has to be applied. It has to be a part of this. And so I would say it's premature in a setting where you can rapidly transplant a patient, such as live donor, to do those transplants without a waiting period or without local regional therapy. I think that's pretty aggressive. I'm sure it's happening in parts of the world, but I think you may not know who's going to do well and not do well because without the test of time and without the test of other therapies or mutations.
So in those cases, what would be your approach after the transplant? You review the explant, you find a cholangiocarcinoma mixed tumor. Would your approach would be similar as HCC, or would you now treat these patients first with some therapy for cholangiocarcinoma, like an adjuvant therapy?
So we would, it would definitely depend on the extent of disease on the explant. I mean, I would be surprised to see a bulky, large disease on an explant that we didn't know about beforehand. So we're really, what you're talking about is small tumors.
Yeah.
So what we have done is, if there are small tumors that would be more like Milan criteria, we don't really go big on immunotherapy. We do try to sequence those patients if we can, so that way we can find out if there's anything actionable, and then we have that discussion with our medical oncology colleagues about whether or not it would be safe to. Immunotherapies like Durva, where they're acting on PD-1 pathways. It may be difficult. That may rev up the immune response. So rejection is an important consideration. What our most common approach is that we go low with their immunosuppression. We transition to everolimus early for that anti-proliferative type of effect. But observation is going to be key. And then further evaluation if we see something really recur in the patient. But if it's a small tumor at the beginning, I don't think we, on explant, we don't really go, wild on adjuvant therapies.
Yeah, we had a case, and I didn't have as many experience that you may have. We had a case where we found mixed tumor, but then our oncologist said, okay, what to target here? Like if you already cured the disease now, and if there is a new tumor, there is a recurrence of the tumor, then only we'll start some therapy for that. So I had nothing to target here. So
right, I mean
approach.
That's the same approach. I mean, I think liquid biopsy is becoming a big thing. With Signatera tests and other tumor DNA testing from the serum. So I think we're going to get better at this, and we have more diagnostic tools, more precision with where our disease is really at. I think we're going to see that being used in the pre-transplant setting, and we'll use it as surveillance in the post-transplant setting. And so I think that's going to be really interesting, and I think we're going to be able to be more, timing-wise, precise with applying therapies because of those. But right now, I agree with that how you went with that patient. We would do the same. There's nothing to treat here. We would like to know what mutations are there, that in the event there is recurrence, then we have something that a molecular target. Yeah. If there's an FGFR fusion or IDH or something like that.
Let me invite Dr. Lawrence Lau, who's a surgeon here in my institution. Dr. Lau has also an extensive experience in hepatobiliary surgery. Dr. Lau?
Oh, hey. I always enjoy your talks, Mathur. I asked a couple questions in the chat, and I was hoping you could give us some your approach. We've started launching our own, I guess, hilar cholangio program, but we've come across a couple of sticking points. The first is, like, how do you convince your oncologist to give, chemotherapy in the absence of pathology, for example, mass plus stricture? And the second thing was, what do you do? What's your approach in the setting of a, potentially or borderline resectable tumor? Do you give a trial of downstaging? Or do you just go for a transplant?
Great question. To both questions. So I would say with regard to the path. So that's the hardest part, is getting that path. I think we do have a lot of vigorous discussions in our tumor board about this. But I would say that we're very good at, and we're fortunate to have FISH testing available for evaluating anything that's brushed from the biliary tree. So that helps us. If there is polysomy on FISH, there's a abnormal malignant appearing stricture on cross-sectional MRI or on ERC that on a cholangiogram, then we feel like we can go with a neoadjuvant protocol if they're a transplant candidate. If they are not a transplant candidate and there would be somebody that we would consider resection for, obviously then we go with resection and boost tumor, liver remnants and all of that if a liver resection is going to be required, etc. In the borderline resectable case, great question. This, I think, used to be a big problem for us because we would essentially be making a decision up front as to what arm we were going to go with, whether we were going to go for transplant or whether we were going to go for resection. In the borderline resectable case, I would say that if we feel we're not going to get an R0 based on our surgical approach, and we have multiple surgeons here who do transplant and resections and those who just do resections, if we feel based on that consensus opinion we're not going to get in R0, then we go with transplant. However, I would say now that we have really, I think, more improvement in systemic therapy with Durva coming on the market and showing a benefit, we can use that as a test before we commit to the neoadjuvant chemoradiation, because once you do that, your resection option is blown. And so I think you can show, a lot of times you may think something's borderline resectable because there's a lot of edema, inflammation, that may not be malignant disease. If you decompress those patients with stents and then use systemic therapy and Durva or chemotherapy and Durva together, watch for a little longer, I think you can probably better select what therapy you're going to do prior to committing to the radiation or not. If they're resectable, then we recommend resection. But if they are still borderline after that test of time, what we have done, and I have 2 patients listed right now with that exact situation, where they get their chemoradiation and they go for transplant. Does that answer your question?
Yeah, definitely. Thank you so much.
Yeah, thank you. Let me invite, yes, please.
It's a very nice discussion. Just would like to know advantages of ERCP with brushing, so biopsy with stenting over PTC.
So one of the things that with what we have found, is that the local context really matters. We prefer ERC because it's harder to manage the external drains. And when we place a PTC, we want to be sure not to violate the plane of the tumor because of the risk of seeding. We've definitely seen that with tumors growing along the tract and being present on the abdominal wall at the PTC sites at the time of laparoscopy and at the liver capsule. And so we try to avoid that seeding aspect. We get less of that with ERC. But it doesn't mean that it's not feasible or that it's external drainage isn't included. We do allow patients to come through our transplant protocol who do have external drainage, as long as the tumor plane has not been violated. So they're just using it for drainage. That's been, really critical for us. But I think the local context matters, obviously. If your center has more experience and better experience with PTC, that might be the way to go. But I think prior to the drainage procedures, there needs to be a discussion by the clinician and the radiologist about why you're doing it, what needs to be done, and whether or not, how to approach the drainage aspect of things.
Thank you. Let me invite Dr. Prasoon Jalal. Dr. Jalal, please.
Yeah, this is a great talk and fantastic overview. I think there's been outlined by you already, and in the discussion, the difficulty in diagnosis. It's always a challenge, especially with the biliary stricture. And so you mentioned FISH technique, of course. What's your sensitivity and specificity for that? And also in your center, you think? And also, have you used the next generation sequencing like BiliSec for the diagnosis at your center?
Excellent 2 questions. So the sensitivity of FISH is very high. The specificity is probably around 70%. But the sensitivity is very high. So in those situations, particularly in the setting of PSC, malignant appearing stricture, polysomy on FISH with that sensitivity, we feel we have enough information that correlates with the explant pathology that there's something going to be malignant there. We go with a neoadjuvant chemoradiation approach, oral capecitabine liver transplant. I think in the de novo patient, who does not have PSC, that's where it's the toughest, because the FISH, it's not always available, but it is also, I think we lose some sensitivity. So I think that's where it's the hardest, but our approach has been just by brute force. We do multiple procedures to get to that diagnosis when we suspect it, and we definitely, kind of counsel the patients on that approach. With regard to the sequencing, so we are just now learning and applying the BillSec more. With that, we haven't formally integrated it into our protocol, but we are aware that it's happening. Our medical oncologists are definitely, talking the most about it, and so I think it's eventually going to be a part of the mainstay of what we do.
Great, thank you.
Thank you. May I invite Dr. Benedict Maliakal from Nashville?
Hi, that was a very nice talk. I had a couple of questions. When it comes to intrahepatic cholangiocarcinomas and we need to do next generation sequencing, is it always a liquid biopsy or is it a percutaneous biopsy? And are there techniques to, ablate the tract or something to prevent seeding? That's one question. And the second question is, do you use circulating tumor DNA titers to decide on transplant if it is high or if the adjuvant therapy does not decrease the titers or something of that nature? And are there specific mutations in NGS that make transplant not a good option or have specific directed therapy as a better option? And the final question is, if you're in a smaller town that doesn't have protocols like this, is there an easy number to refer these patients to, your center?
Sure. So your first question was about biopsy. And so what we typically do with the intrahepatic patients, we have become more comfortable with percutaneous biopsy, and there is less risk of seeding with that than compared to the Hilers for whatever reason. I don't know why. But we use a fine needle approach, and we typically are applying it with concurrent local regional therapy. So we do a biopsy, get that tissue, ablate the tumor, and a lot of times we're using microwave in those settings if it's a small tumor. And a lot of times those tumors are not arterially avid, so Y90 radioembolization or TACE is not as good anyway. So that's for the small lesions. Larger lesions, I would say, we haven't been aggressive about transplanting those patients yet at all, but we could be getting there. Your second question was about about using liquid biopsies. So we are not routinely using liquid biopsies to establish the diagnosis, but we are, I would say, using it in our protocols regularly, quite simply because if they see our medical oncologist, I mean, this is in the medical oncology world and intrahepatic cholangiocarcinoma, everybody's getting it now. And so we are going to learn a lot from that. With regards to using it in our transplant protocols, so I'm glad you asked that question. We've just now been really talking about how we're going to use it. So as of right now, we do not have any patients where we've used liquid biopsy in the surveillance setting to look for, as a marker of progression. But it's coming. It's coming. So time is still our most important sort of marker of progression. But I think it's coming, and I think it will rapidly be integrated into our protocols. Our medical oncologists really feel strongly about that, so I think it will be integrated in. And then I think your last question was about how to reach us if you are in a small place. I'll put our telephone number in the chat here, but it's a very easy number. And you can also just email me directly. So this is our transplant center referral number. My email is here. It's mathur.amit@mayo.edu. And my cell phone number is here as well. So if you have questions, you can text me, you can email me, WhatsApp, email, however, whatever works.
Thank you very much.
Thank you, Benedict. I have one question, Dr. Mathur. Like, we have now criteria like the Mayo Clinic criteria, where if they follow the protocol, they get exception points after following the protocol.
Yeah.
And again, some centers now it is kind of universal based on the UNOS OPTN has adopted it as well. But what about this intrahepatic cholangiocarcinoma, where you are also mentioning that, okay, less than 2 centimeter or 3 centimeter, they follow, they do well. But how to get this patient to the transplant? We don't have an exception points so far recognized yet.
Yeah, so the points are coming. I would say within the next 6 months, we're going to have the points. So that's going to be a huge boon for these patients, right? Right now, our approach is that, I mean, we're transplanting them based on their MELD. If they have low MELD, our center, we're very big on utilization in deceased donor of DCDs. We go out to age 75 now for DCDs. A broad selection with regard to donor warm ischemia time to help bring in more grafts for these patients who have these transplant oncology indications. For that matter, it's the same with our colorectal mets patients. We have to be quite broad, but as the transplant oncology MELD exceptions come forward, there's going to be a more unified approach for that from the OPTN, the National Liver Review Board, and the MELD points are coming. So I think it's going to be easier in the very, very near future for that to happen. The board approved that, voted on it in a positive way, and so it's just going to be programmed into NLRB in 2025. So I think it's going to be better, but that's our approach now. Even with the MELD points, I would say in our center, we're still going to be having the same approach. And I think that's a good use of those grafts in the deceased donor context is, these are, for transplant oncology, if they're, non-portal hypertensive patients, they're going to do well with those livers. That's going to help it. With more transplant oncology indications, bigger lists, we need more donor pools. So I think that's where we have to be.
And with that in mind, like HCC, we have the downstaging protocol. Will that be applicable, you think?
Yes. So that MELD exception rule includes the requirement for local regional therapy and 6-month wait. So that's very similar to what we do with Milan.
Great. And may I invite Dr. Fahmy? I believe he joined a little late. Dr. Fahmy is one of my colleagues, and to share some comments and thoughts. He's also a great hepatobiliary surgeon. Dr. Fahmy, do you have a minute to share?
Yeah, excellent talk. Thank you so much. I mean, the problem of cholangiocarcinoma has been lingering for the past 20 years, and we still don't have like a definitive approach. But things, as you've been saying, time is things are evolving with time, and I think we're getting there. The small peripheral cholangiocarcinomas, I think that's one of the things that we have to include in our transplant population, and it's coming. Thank you so much for the talk.
Thank you. I think we've achieved more in biliary tract cancer in the last 8 years than we had in the previous 15. And so I think that it's an exciting time and for this for those of us who work on this disease process, because I think our change in approach is going to be quite rapid. I mean, there's we're seeing faster evolution in the treatment than we're seeing it, for example, in pancreas cancer or other hepatobiliary cancers. So I think it's great.
Yeah, like you just said, I mean, I just wonder how is the donor pool how are we going to do with it? I mean, where are we going to get all these organs from? And I mean, I hear you with the pump and the DCD and all that stuff, but still, it's amazing.
Yeah, I agree with you. I mean, I have the same concerns. But I think with the deceased donor context, we have to really cast a wide net, and at least the North America U.S. donor pool is going very heavily towards DCD. I mean, I think that by the end of this year, something like 45% of the deceased donors will be DCD donors. So we're going to become very European, and be very, heavy on DCD. So I think that's going to be, people are going to have to get comfortable with that. Use the technologies that are there to reduce the burden of post-transplant outcomes. But I think, transplant oncology in general, I think it begs for, more live donor involvement. And so, I think that's going to be an important piece as well. But it really will depend on sort of how many patients are coming to your pool for those indications to determine sort of how aggressive you need to be on that side, at least on our side of the world.
Thank you. Thank you, Dr. Mathur, and thank you, everyone. for joining today and also for an engaging discussion. We learned a lot today, and I think this video, with the permission from Dr. Mathur, will put it on the web. And so if you have missed this this live engaging discussions, you can always come back and listen to it, and for your ongoing learning activities. And Dr. Mathur, thank you so much. Thank you.
Thank you. Appreciate the time, and glad to be a part of this, a wonderful lecture series.
Thank you. Thank you, everyone. Bye-bye.